I'm an advocate of finding what works best at each institution. I don't believe it would be feasible to set a national standard for mutation testing in Canada because healthcare is organized on a provincial level. However, I expect that within each province, the process will become more organized and more controlled. What absolutely must be uniform are the expectations of how well and how quickly tests will be done. I believe that you have to adhere to certain parameters of accountability, accuracy, flow of information, and confidentiality, as with any other healthcare activity in a publicly funded system. Mutation testing in lung cancer evolved in a peculiar environment. At first, the tests were sponsored only by pharmaceutical companies, allowing for little uniformity in the approach. We are now transitioning into a period where it is more regulated. Just as it is being done for mutation testing in breast cancer, I believe we will soon get there for lung cancer too. Cancer Care Ontario will fund the test, organize the programs, and demand accountability from all involved. The encouraging thing is that the introduction and implementation of a uniform testing approach is happening much faster in lung cancer than it did in breast cancer. When discussing benchmarks, there are two things to consider: what genes to test for and how fast results should be available. The guidelines from the College of American Pathologists, the International Association for the Study of Lung Cancer, and the Association for Molecular Pathology, which was also endorsed by the American Society for Clinical Oncology, state that all individual mutations with an incidence rate of at least 1% in EGFR mutated lung adenocarcinomas should be included in clinical EGFR mutation testing. The guideline also defines the order in which these genes should be tested. This order will not likely be an issue in the near future when next generation sequencing will allow for a large number of exons to be tested routinely and essentially all at once. As for turnaround time, the current guideline recommends 10 working days. I strongly believe that we can do better than that. Many patients diagnosed with lung cancer do not have 2 weeks to wait for the results to come back because of their overall short life expectancy, which can sometimes be measured in months or even weeks. Using the algorithms that we have submitted to CCO, which prioritize saving time, we hope to get the turnaround time down to around 8 days from the day of sample collection. As an example, when a hospital sends tissue to a reference center for testing, the pathologist at that center selects the area of the tumor for testing. We have proposed that the originating pathologist select the area, which means that the tissue can come in and be tested right away. If tests are batched optimally, the actual testing protocol could be completed in just 36 hours. Advocacy is important in closing some gaps in care. Organizations such as Lung Cancer Canada have been doing a great job raising awareness and funding conferences so that healthcare professionals can discuss disparities in mutation testing. Among the general public, there is a negative perception associated with lung cancer, as well as misconceptions about the outcomes of patients who have been diagnosed with this disease. More advocacy is required to raise awareness of these topics. There is an assumption that lung cancer is the patient's fault because of smoking habits. Furthermore, when I was a medical student, lung cancer was essentially a death sentence. Now at Sunnybrook, there is a clinic for long-term survivors of lung cancer. For someone of my generation, that's sort of an oxymoron. Who ever heard of a long-term survivor of lung cancer? However, we now have the potential to change these misconceptions by highlighting the great advances that have been made recently in fighting this deadly disease. Everyone needs to know that there is now hope for patients with lung cancer, which is certainly something you could not say a few decades ago.